I think the last webinar I did was actually Groundhog Day back in February, and good old Puxatawny Phil, hopefully I didn't butcher that name too badly, came up, saw a shadow, and told us we were in for 6 more weeks of winter. Well, up until just recently, we thought maybe he was wrong, but for all of you in the Northeast and in the Ohio Valley and they're sort of recovering or digging out from that last winter storm, hopefully that's the end of it officially, and we can get ready and actually start to enjoy spring over the next several days. So we got lots of fun stuff with St. Paddy's Day tomorrow and March Madness kicking off. So hopefully we get the snow behind us and start to have sunny days. So today we're going to cover a fair amount of material, and I always preface all of these webinars, particularly from a regulatory and industry market standard perspective, to say the material I'm going to give you is to really the purpose and focus of it is to hopefully drive awareness, a certain amount of education, but by no means am I the authority and source on all things regulatory, CMS, throughout the post-acute care outpatient spectrum. But I do spend a fair amount of time plugged in to the industry, plugged into the various associations, participate heavily in HIMSS and attend all of the associated healthcare conferences I can, and try to stay as up on this stuff as possible. And I know it's a challenge in, when you're also treating, running practices and trying to take care of patients at the same time. So my goal for you is to maybe provide a little bit of education, a little bit of insight, some information, again, drive awareness, and then point you back to the sources, of the material. So I always recommend to go to the source. Go to the source to get the truth. Don't rely on word of mouth. Certainly don't completely rely on the information I'm going to provide. It's meant to be awareness, driving and informational for your perspective. So a lot of content to cover. So the agenda today, just a little bit of an upview. It's hard not to, given the political changes and the administration changes, not to do a little quick review of that, but all the things going on in the last 2 weeks. I get a little bit of an update on the evaluation codes. Obviously no changes to them, but we'll talk a little bit about what we're seeing so far and how those trends and selections by our therapists may correlate to what we anticipated or didn't. A fair amount of an update on the quality standards and updates and programs that are coming. As we know, value-based care is here and it's progressing. Specifically, talk a little bit about the merit-based incentive program, MIPS. What that means, we transitioned from PQRS, as we know, to MIPS. Brief update on therapy cap, as we celebrate its 20th birthday this year. A little snippet on the coding initiative. We had some issues with the first quarter NCCI edits. Hopefully the new ones come out April 1st, and a number of those things will be addressed. And then just a handful of additional ongoing regulatory things that we all need to be aware of and be tracking. Some of that are coming imminently. Some of them have been implemented or will be implemented. And then a little bit more information about our ongoing calendar of resources, webinars scheduled we have that you can lock down. And as I said, resources, I give you all the sources and resources where I'm getting most and all of this information from to be able to access and reference yourself. In addition to that. So with all of that, let's get started. So new administration. So we, with the new administrations, and I'm going to do, I purposely went out of my way not to show any pictures of the new president on my slides. I never showed pictures of the old president on my slides, so I'm staying away from that. But new administration, what does it mean to us? Obviously, we get a new Health and Human Services Secretary. So Dr. Price, Tom Price, was confirmed relatively recently, and we have a new administrator in Seema Verma, and she was just confirmed on the 13th. So real interesting. Dr. Price, as you guys probably know, very established orthopedic surgeon, so he's a physician, he's an orthopedic surgeon, and obviously that's interesting, at least it perks my interest up from being a physical therapist practicing for a number of years and the relationships I have and built with a number of orthopedic surgeons. So I don't know if that's going to be a good thing or what is going to be as things go forward, but obviously along with his extensive physician background, he also was in the political arena, both in the Georgia state legislature as well as a U.S. representative for the state of Georgia as well. So he has both a political, and he replaces Sylvia Burwell, and obviously replacing Andy Slavitt is Seema Verma. And I won't profess to know a significant amount about her, but we'll see as things change over the time with a number of the programs and managing that. The priorities really don't change for now, right? So Medicare expansion, that's still a priority. We'll see with, obviously with the new American Health Care Act that's being going through committee. There's reference to that. The mandatory bundled payment models, they're still there, and there's more coming, and obviously a number of insurance mandates. So not a lot of that has really changed. So as we get into, obviously, kind of the big hot topic right now is, okay, with the change in administration, you know, everybody heard the rhetoric around repeal the Affordable Care Act. Well, I think we all have figured out more than likely the Affordable Care Act in its entirety is not going to be repealed. There was too many positive or good elements in it for both us as providers and for patients as consumers of healthcare in this country. So, but what I did want to just pull up is just some nuggets, obviously, with the American Health Care Act that's out and going through committee and getting a lot of attention. You know, what are some of the differences that, or some of the things they're targeting in the American Health Care Act? If you read all the pundits in sound bites and Twitter feed on the American Health Care Act, even a lot of the Republican base, the conservative base, does not believe it's going to go through as is. Without, you know, it's going to be a change. So we'll see. But the big comparisons are obviously where the Affordable Care Act, health insurance was required, and so that was key. Health insurance is not necessarily required in the new one, or certainly the fees or penalties for not having health care insurance are not, don't exist in the American Health Care Act. The tax credits in the Affordable Care Act were completely sort of based on income and family size, and the tweak or change to that is that tax credits in the American Health Care Act are based on person's age and family size. Pre-existing conditions remain to be covered, but there's some caveats to that are in the fine print, so it's not completely apples to apples from that perspective. Essential health benefits are covered in both, but again, there's some tweaks and changes to that when it comes to catastrophic or some other types of things they would like to see different in the American Health Care Act, so it's not completely the same. The dependent coverage, so the children living with you up to the age of 26 as dependents can remain on your plan. That seems to be pretty consistent, not too much deviation on that aspect. And then the Medicare expansion, obviously, there's a number of states that have adopted Medicare expansion. There's a number of states that still have not, even some very large ones like Texas. The American Health Care Act calls for Medicare expansion, but enrollment freezes in 2020, and so we'll see how some of these things play out. Obviously, it's an interesting thing to watch what sort of whether it's the American Health Care Act or Affordable Care Act version 2 or as amended evolves over the next several weeks and months in the legislature up on the Hill. So that's all I really want to cover in the political landscape, and I think we just need to, you know, keep an eye on what is it going to mean to us and what is it going to follow. I did want to update just on the new evaluation codes we're all adopting from Jan 1 and using. So kind of as a brief review and review only from a PT side, you know, we removed the previous 9701 and replaced it with 3 new codes with varying complexity, so 3 different categories of evaluation. Obviously, there's a lot of the criteria around that, specific criteria around comorbidities, et cetera, that we have to take into consideration. And if you want more information on that, I did a complete detailed webinar on that, including a lot of clinical vignettes, but I'm sure you're all used to and getting used to selecting the right one based on the various criteria in each of the categories. But so we have the 3 levels. replaced it, and the eval was a straight 1-for-1. Obviously, the interesting thing was that we get paid the same, right? So the RVU did not change. It's the same regardless of which one you pick. So there's no, for lack of a better term, financial incentive to pick one or the other, but clinically, I think you'll see with some of the data, I think it looks like we're doing a pretty good job of appropriately picking what we believe to be the right category or complexity of evaluation for each patient. Same thing on the OT side. So we replaced the 97003 and 97004 re-eval code with the new re-eval code for OT and the 3 new e-eval codes for OT. We're still seeing, and I wanted to mention this, we're still seeing some payers laggard that, and what I mean by that is all HIPAA-covered entities were supposed to adopt these codes Jan 1. What we saw was a number of payers were not ready. I don't know how hard it was to get ready replacing one code with 3 codes, but some of them weren't ready, and that caused some issues, I know, for some of us in this space. But obviously the non-HIPAA covered entities like your auto, your legal, your litigation, and even your workers' comp were not required to adopt them. But we did see a lot of the big work comp networks go ahead and start adopting these new codes. So from what we're seeing and on the results from our analysis, it looks like a majority of payers outside of auto and legal are really have adopted the new codes. So what's the difference, or similarities to the previous and some of the things that we talked about from HIPAA covered entities, et cetera. So there's still on-time codes, right? There's still sort of a bundled code that includes assessment activities, communications, medical review, and your documentation time, et cetera. From Medicare's perspective, you can bill treatment that same day, so you can treat the patient. And now some payers may not approve that. They may only approve the eval, not treatment of the day. So you need to look at the payer rules around that. But from a Medicare perspective and regulatory perspective, you can. The only thing you can't bill is you can't bill for additional tests and measures. So some of the additional test and measure codes, like a physical performance, you can't bill that at the same time, or significant manual muscle testing, assessment codes, or strength assessment codes, et cetera. Those assessment codes are conflicts or edits on doing those the same day. So on the HIPAA covered entities, we noticed that some state Medicaid programs who should have been Cigna, United Healthcare, Humana, Aetna, all had some, all should have been, but we noticed there was certainly some blues. I think Aetna and Cigna, they're in different areas of the country, and even one of the Medicaid issues in the states or programs in the states had an issue getting ready for the codes. So they're still accepting the old codes, but I say march ahead and continue to do the selections you have and using that breakdown. So let's look at some results. So we took an analysis of some of the results from the people that we have as clients and customers. And so it was an interesting thing if you look at the utilization of the codes or selection. So when you look at the low complexity, moderate, and high, you see that from a PT perspective, 51% of the eval codes given this first 2 or 3 months are being low complexity, 43% moderate, and a very small percentage are high complexity. And I'll preface this to say with both of the sets of the data I'm going to share are almost exclusively from private practice and pure hospital outpatient, non-attached hospital outpatient facilities. So that's not completely surprising, right? So it's not including your home health, it's not including Part B in the hospital, it's not including skilled nursing. So where you you're going to see more complex or more involved patients, which you would expect to see some variation in this. The interesting thing, though, is the APTA provided some sort of a prediction of how they thought the codes would break down. And again, in fairness to APTA, not that their prediction was so wrong here, is their prediction was across the board, right? All settings of physical therapy, this is how they see the breakdown. But I thought it was curious to see the difference from what we're seeing, certainly with the clients using our software, on the outpatient side, how it's comparing to the prediction. And yes, we're seeing a big chunk, but the big differences obviously lie in much higher low complexity and significantly lower utilization than anticipated in the high complexity. So I guess maybe a shout out to the American Occupational Therapy Association, and since OTs turned 100 yesterday, that's a good birthday celebration for them. So utilization we're seeing now, it's a much smaller subset because our clients on the outpatient side don't do anywhere near the level of occupational therapy services provided as they do for physical therapy. So when you're looking at 150,000 results set to 12,000, it's a much smaller sample. But it's interesting to see the OT prediction, utilization versus what we're actually seeing in our clients is very close, almost bang on accuracy. So again, we'll be tracking this. What's probably the most important thing to note about this, and why I think it's worthy to provide you some of this data and some of these results, is CMS is going to be analyzing the data they're receiving over the first 5 months of the year. So from January through the end of May, they're going to be looking at the data and what's been selected, et cetera, and they're going to be using that to potentially come up with new or revised RVU values for these codes that will become effective January 2018. So those are things we may see in the new Medicare physician fee schedules that come out in the July timeframe. So important to say, keep using the criteria, keep using your wisdom and discernment and your clinical judgment to make sure you're putting and you're selecting the right complexity of code for these patients, because it does have significant value. And once again, this data does not include your skilled nursing Part B, your home health Part B. So it's really purely private practice and kind of freestanding outpatient rehab hospital centers. So some tips and tricks just to wrap this section up. So, make sure you're picking the right complexity. It's supported by your documentation. So is it clear the comorbidities? Is it clear, what assessment tools you're using, and looking at you're looking at limitations and activities, et cetera. Don't upcode based on the complexity. If make sure you have to meet all of the components, right? So if you have 3 out of the 4, you can't say, well, it's more than. No, you have to meet each of the components, as we know. One evaluation code used per day per discipline. It's important to audit your HIPAA-covered payers. I'd be looking at, what are you seeing? Are you seeing trends? Are you seeing good selections? As you're doing some of your own chart audits or utilization reviews, those are good things to be looking at. Does it seem like the codes are getting picked correctly based by your staff effectively? Obviously the billable assessment codes and evaluation codes can't be used in the same day, as we said. So you can charge for either of the following combinations, right? You can do eval and treatment, or you can do one of the physical assessment codes and treatment as well. So let's get into the quality update. So we get into the quality update. There's a lot of material to cover, and again, this is going to be a sort of a flyby for all you folks. So, we've got an evolving payment system, right? So we kind of, what used to be completely across the board fee-for-service, we had some quality reporting programs that started a little while ago, with PQRS, functional limitations sort of reporting is still with us, manual Medicare review we had, with us. So now we've moved into, now we're on these complexity-based evaluation codes. So we have these tiered codes. We're now getting more outcomes-based payment. We're seeing that with more and more alternative payment models. Obviously, the comprehensive joint and the cardiac models coming out, the hip fracture models are coming out. So we're seeing more and more of these alternative and value-based payment models. And obviously, where we're going is, episodic payment based on meaningful outcomes. So we're tracking that. So this value-based chain is continuing to progress, whether we want it to or not. The days of fee-for-service are vastly fading in the distance, and we're in the midst of this. And despite the changes of the administration or the political landscape, we are going to move. All of this value-based stuff isn't all of a sudden going to go away and be repealed with a new a new administration. So we just really need to be prepared for it. Keep in mind that CMS's goal is to move 90% of all Medicare reimbursement toward value-based payment models by the end of next year, by the end of 2018. And the other thing to keep in mind as we move for value-based care is there's already the private payers. So Aetna, Cigna, Blue Cross are already developing their own value-based care programs to manage their own costs, right, to improve quality care for, their members and to drive better what they believe to be member satisfaction. So it's not just a CMS thing. It's vastly quickly becoming an overall across the board thing we need to get a really good handle on. So here's a slide you may have seen before or similar. Certainly, EPTA uses a very similar slide, et cetera, to talk about the changing quality program environment under Medicare and the IMPACT Act, et cetera. So from a healthcare setting, kind of down the left, got alternative payment models in all settings. The reporting levels are either at the episode or at the total population. The populations are more like the medical homes and ACOs. Episodes are the specific things around the cardiac bundles, the CJR, hip fractures, and then the payment and incentive penalties tied to those. So then you get into your long-term care hospitals, your inpatient rehabs, your skilled nursing facilities, and home health. That reporting is all at the facility level. Obviously, the IMPACT Act, the huge driving force from 2014 coming out, for trying to get a standardized data set, right, and quality measures across the post-acute care settings. We're seeing a lot of that, and there's some of those things I'll talk more about, but obviously those things are coming, and that's obviously going to evolve into value-based quality program with the impact implementation over time. And on the outpatient side, we've got individual or group reporting either by tax ID or MPI, or reporting at the patient level, like the functional limitations reporting at the patient. So we've had this PQRS, which is now MIPS, kind of takes over part of that and evolves it into something even more, and it's completely driving to value-based payment and the functional limitations based on the condition of the patient. So again, just an update of the various programs, kind of all, if you notice, if you go all the way to the right, everything's kind of moving toward some sense of value-based, and the move toward from a data collection and standardization of the similar tools to be able to really do compare and contrast across the settings, which, pardon the pun, is literally an act of Congress, given all the different tools and sets we use today, and the fact that even outpatient, we don't have a standardized one, unlike home health like OASIS or the MDS, et cetera, like we do in the other settings. So quality programs, they're starting to come together. So when you talk about the quality programs, the QPPs, right, which are your MIPS and your alternative payment models, et cetera, and the IMPACT Act, what are they driving? They're driving the cross-setting quality measures. So measures that can be tracked across all of the settings. We're moving to more of an episodic payment model, and obviously interoperability is key. Right? So the ability to exchange and share data as the patient moves from setting to setting is absolutely, one of the key elements in something that's been a challenge, and certainly from an IT perspective has been a challenge. But the technology problems have been solved and are continuing to be solved in sharing data. And we've seen a lot of that in the physician world and in the acute care world. Will continue to come. So a quick update sort of on the post-acute care settings and the impact timeline. So you all are familiar, obviously, with Section GG and how that impacts home health and skilled nursing, inpatient rehab, and long-term acute care. And I did not include on the slide, but everywhere where you see a reference where there's a little asterisk, that's just an asterisk indicating it's associated to the care tool. But as you see these different quality domains, they're looking at the functional status, the skin integrity, Medicare reconciliation, obviously major falls, and patient preference. And you can see some of the dates in here, a number of things hitting in home health, some things hitting later this year from skilled nursing and inpatient rehab, et cetera, as we kind of continue to execute on the IMPACT Act and the things that laid out to drive consistency across that post-acute care setting. New resource use measures, are coming. Medicare spending per beneficiary and tracking that, and obviously discharge to community. And as you've seen with what things that have already been put out in some of the value-based models, certainly in the skilled nursing and home health, et cetera, and particularly in the skilled nursing side, a lot of focus around readmissions, right? So whether tracking the unplanned readmissions, preventable readmissions, and I think there's a number of providers who've done an amazing job at really affecting this very, very well. But the big focus on managing and driving cost in both the inpatient rehab, skilled nursing, and home health for readmission, discharge, and managing all of those elements, and obviously all of those quality measures associated to each of those. So, quick update on the skilled nursing value-based purchasing program. Obviously, the incentives to this program will start being applied to services in October 2018. So it's for the calendar year 2019. So, it's a little bit away, but again, big focus on those quality measures. The same thing. It's around, excuse me, around the readmission rates, both all-cause readmissions and the preventable readmission rates. So those are things that obviously in the skilled nursing facilities and you're providing services, these are things you want to be very aware of, tracking, managing, and I recommend with all of these value-based programs, and I've done this on the outpatient side and the private practice side, that you designate somebody either in your organization or at your facility that is someone as a key advocate to continuing to keep your staff updated on this and ends up being your go-to person who, maybe that's the person you send to different conferences or educational sessions, and because it's very key that we stay involved, engaged, and ahead of this, and we don't wait till a week or a month before some of this stuff become effective. Same thing on the home health value-based purchasing model. Obviously, this has been going on in Medicare certified, home health agencies in the selected states were required to participate. The states listed. All of you are, I'm sure, are in home health are aware and following this. Again, big focus on the readmissions and quality measures, et cetera. So the first payment adjustments will start to be seen. Like everything we do, PQRS, whatnot. One of the big challenges is the big lag we have. So performance data from 2016. So from last year, you'll start to see, this will be applied sort of up or down starting in 2018. So again, keep on top of that. I think a lot of the reporting data is out or coming out, so you can see how your performance, what your performance scores are, and managing and tracking that. But these things are continuing to move forward. Quick update as we're kind of getting near the end of wrapping up quality is changes, no changes on the horizon that we're aware of, we've heard about, or even talking to APTA or AOTA, et cetera, and some legislators on the Hill to the functional limitations reporting. So we'll see, but a whole bunch of preliminary data was released from the 2014 analysis. So interesting, there was over 166 evaluations, 1.1 million visits. 92% of the evaluations included the functional limitation data, which actually isn't bad, but if you thought back to 2014 when functional limitations there was a lot of confusion around its original deployment and the implementation of that. So that's actually very good. Discharge data that was included in the eval, so those one-time visits, where you eval and discharge in the same day, was only about 9%. And this number was actually higher than I thought. Formal discharge data was in approximately 37% of the episodes. So the reason I thought it was higher is when we see in private practice or an outpatient rehab, on the hospital side, the self-discharge rate by a patient traditionally has been 65, 75, or higher percentage. So where the patient just stops coming, and you never really have that opportunity to close the case down as effectively as you like as a treating therapist. So that challenge, it's difficult to capture that functional limitation data on the discharge, and that was a big certainly a big question that came up when we implemented functional limitations reporting. So 37% we did, I remember being, I think it was at CSM earlier this year, where we surveyed the crowd. There's a pretty big crowd, a couple hundred people in there. Everybody thought it was going to be, I think the highest someone said was 20 or 25, as low as like 5% would have discharge data. So you're going to see more information on the analysis and the reporting of this, and as it relates to diagnosis and a number of things. So as that stuff comes out, I'll be talking about it either on a blog or on Twitter and referencing people back to that. So it's going to be interesting to see how this is going to evolve and will play into quality decisions going forward. So kind of a little bit of a value-based timeline. So 2016 or last year, the CGR models, the PQRS data we were still collecting all through last year. Obviously, that data will impact either the penalty or no penalty for 2018. And then this year, 2017, MIPS is active for the physicians, and certainly they've got a number of different methods in which they can participate. But from us, it's voluntary. We do not have to participate. However, everybody is recommending continuing the participation. And given the fact that, as you said, that the value-based train has left the station and we need to be on it, it's something we probably, everybody, including myself, I'm recommending continue to report quality measures. We're going to have to, and so trying to go dormant for 2 years until we may be forced to in 2019, I just don't think it's a good idea. We need to get in the habit of it and start looking at our patients from that perspective as well. The cardiac and hip fracture models would begin, the deployment date or implementation date, I think, was just delayed, but I think they're going to start sometime this month. So those are coming, and there's more value-based models that are projected and to be coming. So those are good things to be keeping aware of. Obviously, next year, MIPS is still voluntary for us. The question is in the physician fee schedule, are we going to start to see some more, some proponents of an episode payment model? What will we see in the physician fee schedule? How will payments start to evolve? 2018 may be early, but there's also a number of things we need to keep our eye on this year. And so I expect that we'll be doing a lot more besides the quarterly webinars that I do. If there's anything that comes out that's significant to our industry and affecting our providers and our clients, certainly I'm going to gather that information, but I really recommend to stay really plugged in to the Beltway and things that are going on that could impact us. And then 2019, obviously that's the goal for standardization for all the PAC measures and data across those settings. That was laid out by the Impact Act. MIMS mandatory, so we know we won't be required to participate any earlier than 2019, but there still is a question. And when I was at HIMSS, spent a fair amount of time with some of the folks from CMS and talking to them specifically about physical therapists, occupational therapists, and speech therapists, and where what has been discussed around rehab providers, and what confidence level do they have that we'll be inclusive in 2019, and what other changes will we see in the program that will support our quality reporting, so we're not being forced to report quality measures that don't really make much sense for our setting and for the patients we're treating. So sounds like that's still, right now I'd say it's 50-50 in my opinion. But we'll continue to see how MIPS evolves. Obviously, we saw that they had to back off the required MIPS participation on the physicians for this year, so it'll be interesting to see how this evolves as well. Same thing, new episode payment model. I don't know if we'll see one next year, but it's coming. So again, just stay plugged in and be aware as we start to move forward. So not that you haven't had enough of the merit-based incentive payment system, or MIPS, which is all part of some of the value-based stuff, and certainly a big proponent of MACRA. So let's talk a little bit about MIPS, because that is somewhere we can play today, and we probably should be participating. So when you look at the MIPS timeline, it starts obviously on the left in 2017. It's starting for physicians and a number of other providers. as well. And so, obviously it's got that 2-year lag, just like PQRS did. So, whatever they're reporting in 17 will affect their 19 payment, right? So the adjustment is up or down, sort of. So in 19, those participants will see a 4% up or down, and then 2020 a 5%. And then when we come in, so if we come into the picture and we start reporting in 2019, we immediately jump to a 7% up or down. Well, that's a big change from what we were used to on the PQRS measures, where we were seeing, initially a half, 1, 1.5, 2, percentages. You start talking 7%, you start getting into pretty significant change up or down. So understanding that reporting, and I think that just lends more credence to why we should continue to report the PQRS measures as part of MIPS under the quality section. So, and then you can see, obviously, the alternative payment models is another option or path you can go down to receive bonuses. I don't think we'll see a lot of PTOT and speech providers, following that because of the way that thing's structured, but MIPS definitely is something that's going to be very consistent for us and for us to be actively participating in. There's going to be a lot of information coming out with MIPS, just so you stay plugged into it. So when you look at the MIPS categories, so how it's broken down is quality, clinical practice improvement activities, advanced care information, and cost. So cost, we're not going to really have to do anything. Cost is going to be based simply on, claim data, et cetera. So we're kind of focused on the first three. Well, the quality measures is basically, that's replacing PQRS, right? So those are those measures we report, and there's various mechanisms to report. Claims-based, which we can still do today, through an EHR or through a registry. And so most of us are doing, the high percentage of us are reporting, we're reporting PQRS through claims. And then the next highest was through a registry. And so you can continue to do that. And then the clinical improvement activities is a brand new category for everybody, not just for PTs and stuff. But that's not something for us to participate in this year or next year. And then the advanced care initiative really replaces what everything was, very, very much what was defined as meaningful use, and replaces the meaningful use criteria that existed for the physicians in the acute setting. And then I said cost replaces the value-based modifier, et cetera, but that's going to be claims-based. So let's talk about quality, because that's kind of in our wheelhouse. So it said the quality measures replace PQRS. So, and it's, also places the quality portion, the quality portion of the value modifier. So currently this includes PQRS measures, some registry developed measures, and new specialty measure sets. But in that little box below are the 6 sort of PT, physical therapy, claims-based measures you could continue to report, very familiar with what we have been reporting. You can continue to report today as part of MIPS from a voluntary perspective. And so that's not all inclusive, but that's the claims-based ones, and those are ones you can continue to report. And if you have gotten your staff into the very much the routine of reporting them and when to report them, you continue down that path. So how do they, what's the difference from PQRS to the MIPS quality measures? What's the same, what's the difference? So PQRS, as you know, was a percentage of Medicare patients for whom PQRS data was reported, so greater than 50%, right? And then the scoring was either pass, fail. When you look at the MIPS, the performance is based on a benchmark. So percentage of patients whom the performance was met, right? So you're compared against other providers from a benchmark setting and what the benchmark's established at. And then PTs can earn points, plus or minus based on performance. You're also required to meet a reporting threshold. And we really had some reporting thresholds because on the PQRS side as well, because you couldn't just not report. You couldn't report like a null measure and say you reported. You basically had to report something, and some of that came up with a lot of the PQRS denials we saw over the last year or two. But there's a little bit of the difference in how the quality measures reporting compare from the PQRS to the MIPS ones. So when you look at the other category, improvement activities, you know, this is attesting to participation in activities that improve. So this is this new category, right? So clinicians, you know, can choose from 90+ activities under 9 subcategories. No clinician or group has to attest to more than 4 activities, but those things obviously are expanded practice, population care coordination, beneficiary engagement, you know, with the big buzz you hear about patient engagement, you know, driven out of some of these things, care coordination, obviously the transition of a patient from one setting to another, participation in alternative payment models, you know, achieving health equity, integrating behavioral and mental health, emergency preparedness. Some of these more than likely are not going to be very pertinent to our settings, but that's what those are. And then advancing care information, this is the meaningful use replacement. So again, promotes patient engagement and the electronic exchange of information using a certified EHR technology. It ends and replaces the Medicare Meaningful Use Program, as we've talked about. All MIPS eligible providers are included in this category regardless of inclusion in the meaningful use. And what's important about that is we've had a lot of people talk about, you know, can I qualify for meaningful use incentives, and mostly on the hospital outpatient side, without understanding that PTs, OTs, and speech providers were never considered eligible providers under meaningful use. So none of those incentives that were available under meaningful use were pertinent to us. Now, there's basically what we're saying here is now all MIPS eligible providers you know, are here. There is no incentive except for the percentages up and down on the reporting, but if you don't think because you weren't in meaningful use that you obviously don't have to do this. Probably the biggest and most important thing to understand or realize is successful MIPS reporting will require the use of a certified EHR technology. So, if anybody is still heads down on paper, documenting on paper, or you're using someone who's not a certified EHR, and you're not aware if they're planning to become a certified EHR program or technology like we are, that's something you need to be thinking about, because in order to report successfully come 2019, you must be using a certified EHR technology, and so you will not be able to successfully report. So, and if we hit it in 2019 and you're not using that, you will not be able to report. You will be subject to a -7% on Medicare for the 2 years later. Cost, obviously, clinicians are assessed on Medicare claims data. So again, we don't have to do anything from a cost perspective. It's all going to be based on the claims that are being assessed. But the cost measures, you know, the attributions, historically they base it on a plurality of services for the E&M codes. So they're going to be looking at the, you know, eval codes and stuff and different things from a cost measures. Change in methodology in which, with the introduction of these new patient relationship codes that are required under MACRA, and there's a laundry, well, I would say there's a pretty big list of them. So, and it looks at different settings. It looks whether something's a broad and continuous treatment versus a focused treatment, whether it's episodic, whether it's ongoing care. There's a big list of them, and I'll make that list available. You can look at them, but they're all just proposed codes right now, right? But these are things we may see more. We may see more details on those in the fee schedules coming out, and as these codes become more prevalent, because they are required under MACRA. So, who's included or who's excluded? So obviously, if you're newly enrolled Medicare therapists, clinicians, et cetera. So if you just got enrolled today, and if you had to report this year, you don't have to report. You won't have to report until the performance period next year, right? So, so if someone's starting in, you know, someone starts in 2019 or March or April or May, they're not subject to reporting, but they would be subject to reporting the following reporting performance year. Also, clinicians who are on the low volume threshold, and they determine this to be, you know, Part B allowed charges less or equal to 30,000 in a calendar year, or 100 or fewer Medicare Part B patients in a calendar year. Those were what they call low threshold and wouldn't be subject to the reporting. And then if for some reason clinicians were significantly participating in the advanced alternative payment models, they also, because that's an alternative model to report on, then you wouldn't be required, or you would be excluded from MIPS, because you kind of can't get both bonuses. if that makes sense. So one of the things I did want to touch on just before we jump into the CAP, and I know we're getting moving on time, are some of the things that, you know, and I didn't get a slide for this, but I may add it when we send it out. What do I need to do this year, right? So for everybody who's in the facility setting, sort of part A, you know, here's what I would recommend. You know, prepare for the new data elements that are coming in Section GG, right? So you're familiar with Section GG and reporting those functional things, but prepare for the new data elements that are coming. Be familiar, be very aware of your facility's performance on the quality measures, as they may start to directly influence what you're doing or not doing. In the facility setting, or Part B, so in those facility settings, you know, your home health, skilled nursing that are Part B, implement the quality measures in your practice and stay tuned for more information on MIPS. So start using those quality measures from a Part B perspective and start getting used to participating in MIPS, again, from a recommendation perspective. And then from a private practice or pure outpatient setting perspective, you know, continue to submit what you've been doing with PQRS, right? So continue your quality measures you're familiar with submitting, and continue to get that, get the feedback, manage that. Make sure you're incorporating technology into your practice, because I would say a lot of the facility setting, Part A and Part B, are already using technology, where we still see a pretty big gap in people are still using paper to do their documentation or some alternative solutions to do their system. We see that a lot in the pure outpatient settings and freestanding clinics, and really that's something you need to start considering to be able to support and meet the MIPS criteria. And then start to really look at your costs. So since we're moving to an episodic payment schedule, if you don't have a good handle on what a patient costs you for an entire episode, those are things I would start doing some research and analysis on, and start looking at that, because as you start to see what payments may be on an overall episode, that would be very, very good information I would not want to know running my business or running my practice. That's what I would be having my practice, all my practice settings do, that ones I used to be part of, just looking at those costs from a patient's episode. So let's jump into the CAP. So as you said, woohoo, it's the 20th anniversary of the therapy CAP. So, you know, thanks to the Balanced Budget Act of 1997, CAP came in, and here we are 20 years later, we've still got it. And kind of what I said, Groundhog Day, it's here we are again with, we had a repeal for a couple of years where they pushed everything down the road, but at the end of the year, the exceptions process expires yet again for adding the ability to add the KX modifier, et cetera. So it'll be interesting to see what happens. So the CAP is 1980, and that's a shared CAP for PT and speech and a separate CAP for OT, as you all know. The exception process, both PTs and OTs and speech therapists can attach a KX modifier to claims for services that exceed, whether it's the joint PT speech CAP or the OT CAP. Obviously, when you use, you need to make sure that your documentation supports the ongoing medical necessity to meet Medicare requirements for payment, right? You can't, you know, don't get into just some sort of a practice of doing it whether it's necessary or not, right? But I think everyone's got a very good habits and behavior with respect to that. So I said that Congress needs to act, and so there is a bill actually to repeal the CAP again. You know, we introduced one last year. It had a fair amount of legs. It kind of just lost by a relatively slim margin compared to previous attempts. But House Bill 807, Senate Bill 253, you know, I track those on the government site and get updates on Twitter as to what's going on with those bills. So it got reintroduced in February. It is getting some traction. Some of the nice things about this bill from is there's a fair amount of cost saving tied to actually repealing the CAP from an administrative perspective. And so, again, not trying to be political, but we've got a current government administration in there is all about cutting costs from government oversight. This may have the best chance ever to get this repealed, and one way or another, we're going to have to deal with whether the exception process expires or not by the end of the year. So just stay tuned to that. Quick update on the NCCI edits. I know as we're getting near the top of the hour. So, you know, the NCCI 23, the edits got released at the beginning, near the end of the year, beginning of the year. It covered the first quarter. So one of the big things you probably know was there was some errors in there, particularly around PT and OT eval combinations. And I've listed them there, 97162, 165, 163, 165, 165, 164. And so those were causing denials and edits with that perspective. So CMS did issue a technical direction letter. I never was able to get a copy of it to the MACs that to put a workaround in place so they could bypass those edits and pay those claims appropriately and not withhold it. And the changes are supposed to be made and correct that corrective action with the new edits table that's going to come out April 1st. So in addition to that, so keep your eye out for NCCI 24 correct coding initiative edits that will come out. That covers the second quarter, and we're going to be making some cheat sheets available specific to those edits because it's always important to look at those edits and have a good handle on those edits as well as we're making some technical changes to automate some of that those edits and modifiers as well to make that even easier to manage. So, but be aware if you had some claims, continue to go back to your MAC or your FI, et cetera, with respect to these, and make sure that they're implementing the workaround and not denying those claims or those code combinations outright, and you're getting paid for that. Additional regulatory updates. So we kind of covered one of them. So the Medicare therapy cap repeal, as I said, it was introduced in February. I think it had 65 co-sponsors in the House and 13 in the Senate, and APTA, I know, was diligently working on this, excuse me, to get this, continue to push through and to get traction. And then the other thing was targeted manual Medicare review. As you know, we transitioned with MACRA. We had that mandatory manual Medicare review once we hit the max threshold. Well, obviously, MACRA kind of changed that medical review process for Part B services. So now it's certainly there, but Strategic Health Solutions, who's a subcontractor, is kind of doing post-payment analysis on this. And so obviously what they're looking at, you know, is the aberrant billing practices, high claims denial percentages, new enrollee providers are being more heavily scrutinized than people have been on the system for a long time, specific medical conditions that may warrant increased scrutiny, and groups that include other therapy providers in the review. So we're looking at, that's just some of the criteria. And again, so it's, you know, the biggest, can you guys still hear me? Did I lose you for a second? I had a little phone glitch. So the biggest thing to take away from this is the emphasis for that manual Medicare review to be aware of is going to be on the evaluation of the number of units or hours of therapy provided in a day. And so that's a big thing to be focused on. And then a 30-day discussion period, you know, you have to fix minor issues and communicate back, obviously, to Strategic Health Solutions, who's the supplemental Medicare review contractor. But so you're going to see more and more of these, because even the other thing I didn't include in here is the RAC audits are back as well. And you're going to see more of those coming. We kind of got a repeal on RAC audits as well. So the other couple of things I wanted to hit was TRICARE reorganization. So the TOD, you know, selected for Humana Military and Health Network Services to manage TRICARE system. So there's new contracts and they're worth a huge amount of money. But the problem is it significantly reduces the payments and PT payment and physical therapy payment rates. And it changes the way PTs are recognized as authorized paramedical providers. So, and the TRICARE does not recognize the use of physical therapy assistance in any setting in which the military healthcare reimburses for services. So APTA's jumped all over this and, you know, in pursuing legislative action to correct this, specifically the PTA issue. So stay tuned for that. but there's other things coming up with TRICARE that we need to be aware of and be watching. And then home health conditions of participation. So a number of things with respect to that. Obviously, the use of PTs as clinical managers, requirement for skilled services, privacy rights, privacy requirements, patients' rights, care planning coordination, and quality of care, and all this, a lot of this stuff becomes effective July 13th this year. So those are things just to be aware of and be tracking as well. And then the big, one of the big items is sort of the maintenance therapy update. So as you know, the big Jimbo and Stabilis court case, et cetera. So there was some action taken and on this with this decision, but the CMS was very delayed in implementing and upholding the things they were supposed to do. So the court has now ordered CMS to comply and uphold the provision, and so a number of things have been hit CMS. So CMS, has to address this. There's a technical letter to all the MACs on this and Medicare Advantage programs. They're going to publish a new webpage dedicated to the Jimbo settlement and understanding what this means from maintenance therapy to be able to pay for qualified, skilled maintenance therapy, et cetera. So, and there's a big FAQ document that's being, I think it's been posted and will be continue to be updated on the CMS site as well. And CMS has a deadline to comply with all of these things they've been ordered by the court by September 4th. So how much of this you're going to see now, I'm not sure, but they should be honoring it, and they have their date to comply is September. So stay in track and be watching this as you go forward. So as we kind of get to the top of the hour, some of the additional things. So I say we do a regulatory webinar every quarter. So for the second quarter, I wanted to delay it a bit because there's an awful lot of things going on in May, in late May and early June that I wanted to make sure we had the opportunity to include and update you on. And then I'm going to do a special webinar specifically on the physician fee schedule. It'll be published sometime around the first week to the middle of July. That's the fee schedule that will be effective Jan 1, 2018. And I always like to take a really quick assessment analysis of the proposed fee schedule. It's not the final fee schedule, as we all know that doesn't come out until October, November. But and do an update is what this means, because there's so many changes going on from a coding perspective and from a value-based perspective and from a payment model perspective. I think the more we can provide information to you on what implications may occur that you may need to be preparing for is good. And then Q3, we've got it on the calendar for September 4th and then December 7th. And as Megan said early on, and I want to reiterate that we record all of them. So if you know you can't make it, just register. And once you're registered for it, you'll get a link to the recording and you'll get all the slides and be able to listen to it and go through the slides at any time. So never hesitate to register if you can't attend live. I know it's difficult with conflicting schedules, particularly as you get into the summer or some other times, and with heavy patient loads that you all have. Finally, on resources, so here's a number of links, and I've got a few more resources. I'll be updating on this when this comes out, but obviously CMS, APTA, AOTA, ACA, and I'll be updating that for everything. So with that, I'm going to turn it back to Megan to kind of close it out.
Thanks, David. And thank you guys for staying on just a couple extra minutes. Like I said at the top of the hour, and David mentioned as well, you'll receive a link to the recording of today's broadcast, as well as a PDF of the slides. And as soon as we have those cheat sheets that he mentioned a little earlier ready, we'll email those out to you as well. So if you'd like more information on Casamba and any of our products, you can visit us at casamba.net, or you can contact us directly at 800-648-2596. And of course, we would love for you to connect with us on social media. We're on LinkedIn, Twitter. Of course, David has his own Twitter, Facebook, and Instagram. We'd love for you to join us at our next quarterly updates, and that special update on the physician fee schedule will include a registration link to our next session in your email. Again, thank you for joining us. We appreciate your interest and hope you found this very valuable. Have a great rest of your day.